Hey everybody, welcome back. Boy, I'm really sorry we got cut off on number 1. I lost track of time. So here it is on number 2. And just a quick question, let me know if you're getting tired of this shirt yet, because I think I am. So just to go back to where we were, these were examples of coding. And remember what I had shared was that the reason why we have coding is it's in order to identify the diagnosis or the service that was given. So for example, take a medical condition like acute pharyngitis, which is an acute sore throat. Same thing, 2 different words, sometimes called viral pharyngitis. 3 different ways you can call one condition, but the code for that is going to be one code, which could be J06.9, depending on how it's coded, okay? So, just wanted you to remember that, okay? We were talking about, when I got cut off, on claims submission. So all the elements of an encounter, the diagnosis, the dates, the procedures, what the charges were, and what the identifiers are submitted either on paper or electronic for billing. A physician office, they're submitted electronically, but the claim form is called a CMS 1500. And the facility claim form is called the CMS 1450. Notice that CMS, those are official government claim forms. And on an EDI, it's called an 837 transaction. On an electronic claim transaction, HIPAA has very clear privacy rules on transactions on what they have to do. So for example, the NC developed up with these standards. So an 837 is a healthcare claim or equivalent encounter information. Your remittance is an 835. Eligibilities are 270, 271s. These are just numbers that you might run across. So the remittance is the amount of reimbursement that a person receives. And that reimbursement, I might bill for $100. Okay, but the reimbursement received could be reduced amount due to a co-insurance or a co-payment or a contracted amount. Challenges to reimbursement is non-payment by a payer or incorrect reimbursement. Final settlement with the patient is the final payment, and then it's paid for. Third-party reimbursement uses 2 methods. Again, fee for service, which we've talked about before. That's a separate payment made for each service provided. So one to the doctor, one to a radiologist, etc., etc. An episodic care is payment of one sum for providing all levels of services during an illness or a time frame. That's an episode of care. Okay. Other names for episode of care is capitation, prospective payment, and global payment. So there's, again, another traditional retrospective. Episode of care. Managed care may involve a fee for service or episode of care. Now, retrospect means looking behind. Okay, retrospective. The traditional retrospective payment is payment made after the services have been provided. So that's used mostly by commercial insurance or indemnity health insurance policies. Then, traditional retrospective, they have a fee schedule, and that's the list of allowable services and procedures and how much you can get paid for each one. The fee schedule is developed by using historical claims data and the provider's usual and customary charges. Okay, so they use historically. So then you get to a term that you're going to learn about in reimbursement methods called Resource-Based Relative Value Scale, or RBRVS. That's a payment based on the cost of services of that provider in regards to how much effort it took, what their overhead costs are to run their facility, and what their cost for malpractice insurance is for their region. So the RBRVS in Iowa could be a lot lower than it is in California. The effort might be the same by the doctor, but the cost of overhead of running that clinic or that facility might be higher in California, and malpractice costs might be higher in California. So RBRVS determines what kind of payment that provider's going to get based on those factors. So it's not equal across the country, and that scale is adjusted. Self-pay is when a patient is responsible for payment for healthcare services. So people in that boat, it could be the uninsured, or it could be people who just self-pay. My grandmother, she was very different. She had Medicare A, she had Medicare B, but at that time you could buy a supplement to Medicare B. She absolutely refused to spend money on that. So when she went in the hospital, anything left to pay after Medicare B, she paid herself. You can seek reimbursement afterwards, like self-insured plans for large employers, and that could be a little bit higher. Episodic care methodology is you get one or more service provided by a healthcare organization during a course of care related to that condition. So it's one payment for services during that episode of care. Now remember, a few slides ago we said that was capitation, prospective payment, and global payment. Capitation, here's the official definition, so you don't have to listen to me anymore. But the healthcare gets a fixed sum per person enrolled in the plan and assigned to that HCO. So a typical payment is the same amount paid per length of time regardless of the number of plan patients requiring care, the frequency, or the severity of illness. So that provider gets a per member per month cost. So they could, let's say you get someone with 1,000 members. Doesn't matter what that healthcare organization does for the members of that organization. They get a fixed amount every month per member per month. So maybe it's $50 per member per month. This is your budget for the month. Doesn't matter how many of our people come see you. Doesn't matter what they need. Doesn't matter what's wrong with them. This is what you're getting paid. So the provider knows that in advance. The provider assumes some risk if they don't know the history of that group and what kind of services might be required. The PPS system, payers are established reimbursement rates in advance for healthcare services to be provided. PPS rates, they look at the average resources used to treat a particular condition. Okay, so for example, if someone has congestive heart failure, what is the average resources needed to treat someone with congestive heart failure? And they look at that data over time, and then they use that average resource to help determine payment rates. That person with congestive heart failure, you can have two people. One might need more care, one might need less care, but under PPS, they get the same amount no matter what. Prospective payment types are per diem. A per diem means just simply per day, based on the number of units. You get so much a day to keep them care. So for example, in a long-term care facility, let's say you got someone who's on Medicaid. Medicaid is paid by a per diem. You're going to get X amount of dollars per day to take care of this Medicaid patient. Doesn't matter if they're heavier care than someone else. Doesn't matter if you have to lift them in and out of bed every day. It doesn't matter if you have to help them use the toilet all the time. You're going to get this much per day for every patient you have in Medicaid. That's per diem. A cost-based payment, or a case-based payment, is payment of a fixed amount for providing health services for a condition or case. So it's case by case. Don't see that one as, well, you kind of see that in prospective payment, but that's usually related to DRG. So here we go to DRGs. The Centers for Medicare and Medicaid Services, or CMS, it's an inpatient prospective payment system. So when you get paid on a DRG, they look at that person's diagnosis. What kind of procedure did they have done, if any? How old they are, male or female. Comorbidities. Comorbidities are underlying chronic conditions that's going to impact that person's stay. So for example, if my mother went into the hospital with congestive heart failure, she has diabetes. Diabetes would be a comorbidity because it's an underlying chronic medical condition. Okay? A complication then is something that occurs while you're in the hospital to complicate your stay. So let's say you have someone who comes in and they have pneumonia. They're being treated for pneumonia. They try to get themselves out of bed. They fall and sprain their wrist. That wrist is a complication. And then their status on discharge. DRG sometimes is based on whether they are discharged alive or if they died. So all of those factors determine what's called a diagnosis-related group. A global payment is a payer makes one payment for multiple providers treating a single episode of care. And in a larger group, it's similar to capitation. Managed care reimbursement, under that, you get a contract with providers to limit fees, so you can have a fee for service or an episode of care again. They look at patient utilization control, and they do this by offering financial incentives for patients to use the network resources, because you can get lower cost in network, and if they go out of network, they're going to pay more. Okay, so that's the end of part 2 in 11 minutes. Sorry it took so long. We have one more to do for financing, I think, and then we're almost done. Thank you.